Hi, I'm Dr. Bobby Connor, and today I've planned to discuss with you some of my thoughts on sedation and anesthesia of critically ill dogs and cats. I've invited my colleague, Dr. Bobby Connor, to join me in this discussion. For some reason, folks mix the two of us up. I don't see it. Me neither. Anyway, the first thing I want to discuss is when to use sedation and when to use general anesthesia in a sick or critically ill patient. What do you think?
Well, if the patient is critically ill, obviously sedation would be safer.
I wouldn't say that's always true. Sometimes general anesthesia might be safer as it allows you a bit more control of the situation since the patient is intubated and likely being closely monitored with ECG and tidal CO2, pulse oximetry, things like that. And it's easier for me to provide supplemental oxygen, and maybe the most important thing, I can essentially eliminate all stress associated with whatever procedure I'm trying to do.
So you're saying you should always use general anesthesia? That's insane.
No, that's not what I'm saying at all. I just want to make the point that it's not necessarily true that sedation is always safer. Sometimes it is, but that may depend on what drugs you're using and what you want to sedate the patient for.
Well, what even is the difference between sedation and anesthesia? We use pretty much all the same drugs, except maybe gas inhalants.
That's actually a really good point. So for me, I remember someone once teaching me the distinction between sedation and anesthesia is whether you can intubate them, not whether or not you do intubate them. If you can, then the patient is anesthetized. I thought that was a nice practical distinction.
So if I give a dog a dose of dexmedetomidine and it's so out of it I could intubate it, you'd call that general anesthesia?
By that definition, yeah. And I like that definition because it's also practical. If I can intubate the patient but I don't, what's protecting the patient from aspirating? If the patient can't guard its own airway, then we should probably do it for them.
Okay, I get it. Can we talk about what protocols we should actually use for sedation so we don't always have to use anesthesia?
Sounds good. What would you use to sedate a 4-year-old male castrated mixed breed dog that got hit by a car and has a bunch of wounds you need to clean and explore?
Is it stable?
Good question. Let's say it was in shock when it first came in 20 minutes ago, but it stabilized nicely with just one bolus of 10 mils per kilo of Elder.
I'd probably use dexmedetomidine and butorphanol, but I'd use a low dose of dexmed since the dog may still have some injuries I don't know about yet.
So you'd use a lower dose because it'd be safer?
But dexmedetomidine doesn't really work that way. The cardiovascular effects aren't linearly correlated to the dose. You get a big, like 50 to 60% drop in cardiac output, even with low doses of dexmedetomidine.
That doesn't even make sense. If there was that big of a drop in cardiac output, how could we even use it in stable patients? It is a big drop in cardiac output, but healthy patients have a pretty big reserve of cardiac output that you don't need at all times. It's like how your cardiac output drops when you're sleeping.
So how much does it drop during sleep?
I'd have to look that up.
So you don't know?
No, I don't have those numbers in my head, but a quick search could probably tell me. It looks like around 25 to 30% in people anyway. So yeah, there's a pretty big reserve available so that healthy patients can tolerate this drop. But lowering the dose of dexmedetomidine doesn't really have that big of an impact. You'll get a sizable drop either way, so I'd say you shouldn't use dexmedetomidine at all unless you feel comfortable using it at a full or with a normal dose.
Okay, let me give you a case.
Sounds good.
You have a 2-year-old Yorkshire Terrier that has hepatic encephalopathy from a portosystemic shunt. While it's waiting for surgery, it's being treated with levetiracetam, lactulose, and a liver diet. It develops a urethral obstruction, and you have to sedate it to unblock it. What do?
For that, I'd probably use a combination of an opioid, maybe a full mu agonist, or maybe just butorphanol, depending on the dog's demeanor, plus some dexmedetomidine and probably some ketamine. Ha! That's wrong. You shouldn't use ketamine in a patient with neurologic signs because it can increase intracranial pressure. Actually, there's mounting evidence that that's not true, and some studies in people actually document a reduction in intracranial pressure and an increase in cerebral perfusion pressure with ketamine administration. In fact, ketamine has even been used to treat refractory status epilepticus. So I would feel completely comfortable using ketamine in a patient with seizures, hepatic encephalopathy, traumatic brain injury, things like that.
You have an answer for everything.
Mostly I just really like ketamine. It's sparing for the cardiovascular system, doesn't affect the GI system, and it's cheap. If it were reversible, it might be the perfect drug. Feel like one more?
Really?
Okay, so you have a 13-year-old domestic short-hair cat that comes in with respiratory distress. He has a history of heart disease, so you suspect congestive heart failure, but he's fractious and you can't do anything with him. What would you sedate him with? You're the worst. I suppose he doesn't even have a catheter, does he? Nope. I don't know, but I'm pretty sure whatever I say you'll disagree with, so I'll make it easy on you. I give buprenorphine, midazolam, and ketamine IM. Actually, I love that. I think there's a good chance that would work really well. I'd probably just use a relatively low dose of ketamine, like 5 milligrams per cat, and I find that combination works well, and it's not a huge volume to give IM. A lot of people also really like alfaxalone, which is completely fair, but it's a big volume to give in the muscle in a cat that's trying to eat you, so that could be a challenge.
How did you manage to be annoying when you agreed with me?
Wait, what? Okay, I guess that's it for today. I'd like to thank Dr. Bobby Connor for joining me to discuss some ideas for sedation and anesthesia in critically ill dogs and cats. Hope to see you next time.
Nice of you to get